it's my absolute delight and pleasure to introduce Dr. David Unwin, my adorable husband. Some of you know him, and some of you know that this year he's won NHS Innovator of the Year for his work at Norwood Surgery. For patients with diabetes and pre-diabetes. David's always been passionate about helping his family, his friends, his colleagues, and his patients, and that's one of his absolute best qualities. Another fantastic quality is a little bit like Zoe, but maybe not quite as much, is that when he looks into a subject, he really looks into it. So we're just all glad that he's not talking today about British moths. But today and most days, and really some nights recently, he's going to be talking about sugar.
Hello. It's my great pleasure to introduce Dr. Jennifer Unwin. And she's also had a very successful year. This is Jen winning Best in Village Show last October, and she is Best in Show, Best Wife in Show. But apart from that, I'm very lucky because she's a clinical health psychologist. And really, a lot of what we need to do is change behaviour. And if we're going to change behaviour, we need to ask an expert in behavioural change. And really, they're called psychologists. She spent her entire life wondering about how to change behaviour. Her particular interest is the aspect of hope. So what difference does hope make for patients in terms of outcome? And she's done a lot of research and published on that. And say that just as I talk about sugar all the time, Jen talks about hope in family life, with colleagues, with patients, with your neighbours. And she rolls that out into our lives completely. Thank you. Right.
Okay, so 3 years ago, we had a little conversation. It went a little bit like this, which was, David, what are your best hopes? We actually talk like this, it's a bit sad. What are your best hopes for, the twilight years of your general practice? And we actually had a conversation about that. And David's best hopes were to go out with a bang and not with a fizz, and to really make a difference. So I hope we're going to show that those things have been achieved. My best hopes was just to work with David, because I thought that would be loads of fun. And it was something we haven't done, and we've never presented before either. So those were our best hopes 3 years ago.
Yeah, the particular interest for me, obviously I'm an older GP now, and for decades I'd watched the health of my patients deteriorate. So people were getting fatter and fatter, really, whole families. I just watched it as the decades. And I tried ever so hard to make a difference by telling them off and lecturing them and starving them, and nothing ever worked. Nothing worked. At the same time, I noticed that the diabetics were presenting decades earlier. So that in 1986, when I started as a GP, people were presenting as a type 2 diabetic. Maybe they were 70 when they presented. 30 years later, they were presenting aged 45. Something has changed in my time as a doctor. Something has changed, and I became interested, what has changed, and can we make a difference? There you go.
So here we are. This is what we've been doing, and this is the again, adorable team at Norwood Surgery. You'll see the partners there, practice nurses, and some of the admin team. Quite a lot of them are now low carb. I think those of you that do this know that it's a bit like a virus, isn't it? You kind of catch it off other people. There's now, the partners used to so generously buy biscuits for the staff and actually pay for those. You don't get that normally in the NHS, but they don't do that now. Okay, so here they are, and we're going to be talking today, obviously, in more detail about the project and how we did it.
Yeah, we love those people. They've worked with us for years. Each of them has become a patient expert and works now in the practice with the group, advising other people how they did it and giving hope onwards. We haven't lost a single person from the beginning. They all stick with us and enjoy it.
And still losing.
And some of them are still losing. The first guy you saw, he's come off all his medication. He was on everything. He was on stuff for chronic pain. He was on stuff for mood. He was on stuff for his blood pressure, and he was on stuff for his diabetes. And he doesn't need any of it. And he's now joined a gym. He has a completely different life. So just going back to where we are now, so there are two things to look at. One is a number of people have volunteered within the practice to join a study group. These are people I follow up more regularly and more intensively, and they form the basis of the publications that some of you may have seen. But we're also moving ahead as a whole practice. So we're a practice of 9,000 patients. There are 5 partners, and we have results as a whole practice as well as the study group. So if we just go through the study group first, these are people who on average have been on the low carb diet for 19 months. That's an average, so some of them of course are less and some are more. If you look at average diabetic control, when they begin they're pretty average really, with a hemoglobin A1C, this is in millimoles per mole, so 52 is fairly average for a kind of not too badly controlled type 2 diabetic. But if you look where they end at 42, that is very nearly completely normal on average. So we've nearly got, if you think that's an average figure, actually the great majority were either in remission or reversed. I don't know what it is, but that's where they are. And many of them had come off medications, as you'll hear later. Next one. Yes, of course, many of them did lose weight. You heard from some of the big weight losses, but the average weight loss on that is about 1.5 stone, or probably about 9 kilos, which is very good, really, and they do keep it off. So I've now, a bit like my moth collection, I also keep I keep graphs of patients that have done brilliantly, and I think I've got about 50 patients now who weigh the least they've weighed in the last 12 years. And that's a lot, really. It is a lot. The next one. Yep. Now, I don't know, do we worry about cholesterol or don't we? I worry about it because other doctors watch what I do, and at the beginning the patients were very concerned about cholesterol. So I said, okay, we'll measure it loads of times and just see what happens. Now the interesting fact is for the 50 on the study group, whether it's bad or not, the cholesterols fell. They just did, and so did the ratios. So the cholesterols, whether that's an improvement or a deterioration, but they fell, and the patients found that very reassuring. Particularly their families were worried about, oh, you're eating eggs, the full fat, you'll die eating full fat yogurt, that kind of thing. So that calmed us all down and kept my partners off my back, really. If we go on to the whole, the practice population, so at the beginning, the prevalence of obesity in our practice was about average for the nation. But as you see, it's come down now. So the average for the nation is 9.4% of a GP's practice. Ours is down to 7.5%. So that's quite, if you're dealing with thousands of patients, that takes quite a lot of doing. And it's because all the other partners are doing this now, and both are practice nurses. Yes, and of course, GPs were kind of fascinatingly paid for good results in diabetes, which isn't why we did this at all, but actually our diabetics, as you see, so the national standard or the national quality that we should aim for is that your patient should have a hemoglobin A1C of less than 59 millimoles per mole. We were average at the beginning, and the national average is about 61.5% of your patients achieve that standard. We achieve that standard now in 69% of our patients, so that obesity is down on the whole practice, the quality of diabetic control is up. And now this is the thing I am most proud of. How much money every doctor spends on drugs is monitored, and these figures are available to anybody that wants to look. And this shows the spend in our area for every practice in the Southport and Formby area on drugs for diabetes and insulin. And as you can see, there is a pink practice, and yes, that's us, the pink practice, and we spend the least. So we're getting these great results, and we're spending so much less money than other practices. And if you calculate it out, we're actually spending £45,000 per year less on drugs for diabetes and insulin than is average in my area, but we're getting better results. And when I saw that, I was really, well, it was champagne time. Thank you. Thank you. Okay, I don't know what happened.
Okay. Come with me now on a little argument as to why we need more psychology in healthcare. It doesn't have to be delivered by psychologists, but maybe we can do some training. You know, I think we were talking about education. It's really key to this, and it's really key to helping the people, the frontline people, to bring what they can to this fight, really. So, chronic disease, David, going up or down?
It's going up and up.
And up. Okay, what happens to well-being when chronic disease goes up, David?
It goes down.
Very good. Great. He's a very good pupil. Okay, but here's the interesting fact, and this is a very robust fact, that the amount of objective disease that an individual has, my friends, does not correlate with well-being. Okay, so you could have two people with exactly the same amount of objective disease on any marker you want to look at, and you'll find that actually doesn't correlate. It's not a predictor of their well-being state.
So that I've got patients with very severe osteoarthritis of the knees, and some of them are out on the golf course, they're line dancing, all sorts of things, and I have other people with, according to the X-rays, very, very similar a degree of disease, and they are very unhappy, they're in pain, and their lives are ruined. So I just agree with Jen there again.
Okay, so if objective disease factors aren't predicting well-being, what is predicting an individual's sense of well-being with a condition or generally in life? How are they adjusting to this challenge, which we know is a challenge because overall the burden of chronic disease, if you have a chronic disease, it does challenge your well-being. Okay, so what predicts what level of individual well-being you have with that? Well, it's probably not a surprise that I'm going to say it's the psychological factors. It's how people make sense of that condition. It's what knowledge they have. It's what they know about other people who've got that condition. It's what the doctors tell them.
I think often it's about people's interpretation and belief around the illness they have. So if you think that the pain you have may be going to kill you as a belief, then you probably feel worse. If that pain is something, I don't know, like childbirth, you probably take it on the chin better if you think there's a good outcome. So people's belief about illness and the way we talk about illness actually affects well-being.
Okay, so we're quite interested in well-being. We like well-being. It's nice that people feel well, they feel happy, and they feel they're getting on with their lives. They have a sense of feeling good. Okay, so I think we're probably all agreed that it's good if people have well-being. But there's some actual hard, kind of really important reasons why it's important to help people who have chronic conditions, particularly to maintain their sense of well-being with that condition. And that's because, and again, these are hard findings, all of these things go down if people have higher well-being. Okay, so medication taking, particularly pain medications, consulting rates, morbidity in terms of like how many symptoms people are experiencing and reporting, and even mortality. So happy people live longer. Okay, so that's really, really robust. So it's kind of important, isn't it? And I think we need to bring that into our work. This can, on an individual level, be improved. There's lots of things that you can do to help people maintain their sense of well-being, and some of those things are things that we put into the project. So, well-being, psychological factors. I do go on quite a lot about hope. So it's my thesis that if we conceptualize people who've got high well-being as hopeful individuals, and what do we mean by hope? You know, it's one of those kind of motherhood and apple pie kind of words, isn't it? And how are we going to integrate that in our practice? Hope is about anticipating a good future, having a sense of optimism about the future. We've got a word for hope in medicine already. I don't know if anyone wants to take a guess what it is. Placebo, thank you. Prozac, yes, no, not Prozac. Definitely not Prozac. We've got a word. Can I just finish? So we've got a. Can I just finish? We've got it's hope in medicine is the placebo effect. We know it's so powerful because we take it out by doing randomized controlled trials using, kind of dummy drugs. It's so powerful we have to take it out to prove that our drugs are more powerful than it. The placebo effect can be 30%, 50% of the outcome that people report. It's a massive effect. There's loads of fascinating studies on the placebo. It's a whole nother lecture. It's massive. We take it out, we forget to put it back in. So the things that I'm going to talk about are about how to rock the placebo in your practice, whack it back in, get 30 to 50% more effectiveness.
Just to go over the placebo effect. So if somebody's in pain and I give them a red little jelly thing and say, take these, they're great, that's going to help the pain. If you use a green capsule, it doesn't work as well. Somehow the placebo works better if it's a red capsule. But that placebo has given the patient hope that they're going to feel better. And anticipating hope is all part of feeling better. In a different way, of course, if you have a disease and you feel like a hopeless victim of that disease and it's just going to take you over, you feel worse. If you believe that you can change your life and improve outcomes, you develop a hopeful state. And that hopeful state is effective right across. It helps with cancer, it helps with pain, it helps with depression. And we should be using it more. Very powerful. And you can get it in there quick. It doesn't take long.
Okay, so in the same way that some of us here are slightly maverick in our own worlds, I'm slightly maverick as a clinical psychologist because I believe it's really important to really simplify these psychological ideas so that we can hand them out. And apologies to anyone who's ever spoken to a psychologist and hasn't had a word known what they're talking about at all. So my next little bit is to simplify how to rock the placebo effect in your practice, but also in your lives. So you can use this on your husbands and wives and families and so on. I'm going to introduce four sort of metaphors that hopefully will illustrate what we've done in this project, but also be useful to people. And if you want to find out more, I can talk to you more about it, or I can point you to the worlds of positive psychology and solution-focused practice. Okay, so number one, and this is arguably the most important thing, is people's best hopes. And I'm representing that by this kind of beacon. It's not a lighthouse drawing you onto the rocks, it's a beacon drawing you to the harbour of what better would be, what success would look like, what you're hoping for in your life personally. Okay, it makes a little, oh no, it doesn't, it's supposed to make a seagull noise, but I've broken it by doing it so many times. So here's our beacon of hope. And we had a conversation about best hopes 3 years ago.
There it is. So my best hope.
Look where we've landed.
Here we are.
Okay. Always really important to start with a person's best hopes. It's really good to know what those are, and you can get alongside them. Okay, so that's my first component. My second component is represented by this rather natty measuring thing that I'm going to actually make stay out. Okay, so if this is where this is where I'd really like to be. It's really good to have an idea of where I am, isn't it, and where we're up to. And of course, this applies a lot to medicine, doesn't it? If this is where we want to be in terms of your results. You know, David was talking about measuring with people and feedback. Where are we now? And also, if we know that, then we know probably something about this next tiny step that's going to get us a little bit nearer to where we want to be.
So very often in consultation, if I've established what the patient's goal is, and those goals can vary. Doctors we have our own goals, but really it works far better to start with the patient's goals. So the patients, they have goals, for instance, like breathing better, having more energy, being able to play with my grandchildren. Or one of the people in the group, her personal goal was she'd always worn black because she weighed 20 stone and she wore the sort of Acne fat concealing things. And her goal was a red dress for a party. And she came to the group in this dress. She'd achieved her goal.
We all cheered.
Yeah, we're all, yeah.
Yes.
So patients' goals really matter because they will and do change, but they're not as interested in my goals. They're not as interested in their hemoglobin A1C or the blah-de-blah, but they're very interested in their lives. And then as Jen has said, if I'm talking to people, can we agree on a small step towards the goal? Now that small step might be a medical intervention, but at least it's a small step that we've agreed on towards an agreed joint goal.
Towards their goal. So my thesis as well is that if you're finding your patient hasn't got motivation, that's not because the patient hasn't got motivation, it's because you haven't understood what their goal is. Okay, so that was number 2. Okay, number 3 then, number 3 of 4 is, okay, so my other thesis actually is that people actually already have the capabilities to get to where they want to go. They've just forgotten, or they're kind of busy thinking about other things. So the third thing is what clevernesses do they have, what skills, what resources, who's supporting them, what else do they know, what previous successes have they had. I could go on and on. It's basically what's in their toolbox, as well as what's in your toolbox, but exploring really what their expertise is and what they can bring to this goal that you can kind of work on together. So that's represented by the toolbox of resources.
If I could just add in there, I think one of the things that is always worth looking for is resilience. Patients have already survived decades of whatever was in their lives. They've survived somehow. They've survived violence. They've survived, all of us have survived things and have resilience. And it's worth reflecting upon that resilience. What is in their toolbox? How do they cope? Because talking about that might lead also to some next steps. If it's working, perhaps you could why don't you do more of it?
Absolutely. And the final thing to tell you about is represented by the magnifying glass. And the magnifying glass is to do with the power of attention. Again, there's a whole another lecture on this, but what are we actually focusing on, and what are they focusing on? And it's my thesis that it's more useful to look forwards than back, because as we always see on Facebook and Twitter, that's not the way we're going. Where are we going? We're going this way. And as a lovely colleague of mine always says, it's a very long day on the golf course if you don't know where the hole is. You're heading that way. Okay, so what are we noticing that's already better? What are we noticing about what's going well, what's working? Let's do more of that. Noticing people's strengths, complimenting people on things, probably the kinds of things that we sometimes forget to do when we're talking to patients.
Just thinking about, if you've only got 10 minutes with a patient, how are we going to spend it? Let's think about depression. So I could take anybody in this room and let's talk about how depressed you are and when was the last really bad day and how did that bad day make you feel and did you feel suicidal and did you feel low and I'm beginning to feel depressed already. Or actually, you could also talk about, well, when was the last happy day and what did you do? And that brings forward a different kind of discussion on goals, what you're going to focus attention on. They already came to you with how bad it was. Unfortunately, we're all programmed to notice the bad. If you can reprogram a bit and notice the good. So over the decades, I've been doing this approach for 15 years at least. And my patients now come to me with their successes, because they know I'm interested. If we train people to moan, well, they will, and the pain. But actually, mine come in and say, guess what, I've joined a gym, or I've done stuff. So this idea of attention is very powerful.
Yeah. Okay, you don't have to do them in that order, but just repeat. Just do that and repeat. What are your best hopes? And we're going to talk about it some more, and we hope to do a demo as well. If we get time, we're hoping to get a demo. So just to quickly summarize my bit then. So hope, really important. We know it accounts for a lot of outcomes and a lot of how people cope with stuff. Hopeful people do better. Okay, so in terms of diabetes, what is our shared direction of travel? Let's go on this amazing journey together. Like you guys, like the Saving Days have been an amazing journey, and that's what we've done with the patients, but it's somewhere they wanted to go. It's about small steps in that direction. Let's focus on that. What's already working? What are you bringing? Who's helping you? What are your strengths and resources? And also, what are we celebrating? What are we noticing? What are we kind of focusing on? Right, that's enough of me for now.
So I haven't managed to talk about sugar at all, and I can't keep silent any longer. So we're going to talk a bit about sugar, but some other things as well. What's the first? Oh, yeah. So I'm very interested in where does sugar come from? That's the first thing. We'll go into that in more detail in a minute. I really like, actually, the idea of green stuff. And for patients, the idea of replace your white stuff with some more green stuff. They understand that, and they do it. They do it. It works. Protein, yeah, that's good stuff. Have some of that. Have some protein. Right, next one. The fats, well, we've talked about fats. I thought that was amazing. So, yeah, have some good fats. For me, we've lost sight. When I was a young doctor, we were taught that diabetes was about sugar. And in fact, old people still call it sugar diabetes now. But somehow we don't talk about the sugar. And it's quite a simple message, really. So what, next one? Yeah, so I would say people with type 2 diabetes struggle to metabolize sugar. And there's so much talk about moderation, which makes me cross. So sugar in moderation for somebody with type 2 diabetes leaves them moderately poisoned. I don't accept moderate health or being moderately poisoned. If I had diabetes, I'd want to be properly well, and I would not be moderate with sugar. So where is this sugar coming from? So the next thing, I like the idea of a sugar spectrum, because you've got to know where you begin. Where are you on the sugar spectrum? Do you know where you are? Some people do, and they say straight away to me, yes, it's 3 spoonfuls of sugar in each tea and coffee throughout the day, and I eat biscuits and all the rest of it. But other people are totally mystified as to where the sugar comes from. Next slide. So, sorry, this is a bit busy, but it's because I've become obsessed with where sugar comes from. This is going to appear, I've got a publication coming out in Insulin Resistance, which is Jason Fung's, he's the editor of this. And so I was really seriously looking at how can we communicate the amount of sugar in different foods. I got together with Jeffrey Leavesey, who Zoe has already mentioned, because he's an international expert on carbohydrate. And we came up with the idea of, could you represent different foods in terms of teaspoons, 4-gram teaspoons of sugar? And of course you can do the calculations so that I can tell you for 800 different foods, I could tell you how many spoonfuls per portion that would represent in terms of the effect over 2 hours on your blood glucose. So that's what this is about. So if we look first, where does sugar come from? Well, I've divided it into 3. There's naturally occurring sugars. So if you look at a banana, a small banana, that would affect your blood glucose over 2 hours. There is a small banana. That would affect your blood glucose over 2 hours to the same extent of having 4.9 teaspoons of table sugar. So you see, this information, if you're making choices, this is about free choice. People can make choices with information, and that's what I don't tell you what to do, but hey, you might like to know this stuff. So we've got naturally occurring sugars, and then we've got foods with added sugars. So how about those digestive biscuits, 100 grams of digestive biscuits? I think it's probably about 3. That's going to affect your blood glucose to the same extent as 8.8 teaspoons of sugar. Again, it's useful information, and you can swap foods through the thing. You could eat something else, and I could tell you how that might affect you. The next group, and this is the group that interests me most, is so many people say, well, I've cut out sugar. So I'm a totally mystery why I'm diabetic, because I don't have sugar. I'm told that every single day, that it's a total mystery. But if we look on the right, this is my sort of starch is sugar category. So foods that break down, they're not sugar, but they break down into sugar. So here we've got bread, spaghetti, French fries, potatoes, these type of things. But look at the brown bread. And if you look, 100 grams is 3 small slices of brown bread, and that will affect your blood glucose to the same extent as 10.8 teaspoons of sugar. So important that people know that. Also, in other foods, you'll see in the New Scientist there that a small bowl of cornflakes without sugar or even milk still affects your blood sugar the same as, I think it's 8 teaspoons of sugar. So you can see how the sugar may be there after all for very many people, and they need to know this. They need to know this.
David, can I clarify one point there? Where does the glycemic index come in with the brown bread? Because that's what people go on
Yeah,
about.
okay, so we used Geoffrey Leavesey was he developed the glycemic index. So we know, that's how you do the calculations, because we know the glycemic index or the glycemic load of any portion of food. And we know the glycemic load of a 4-gram teaspoon of sugar. So the calculations are not that mysterious as to how you get from any food into equivalents of 4 grams of table sugar. And so that's how he did it. Okay, so moving on. A bit more to the nuts and bolts of what we actually did in the practice to bring about the changes that you saw. So we did it in 2 ways, actually, depending on what the patients wanted. We did it as one-to-one, which was me, all the practice nurses, all the other partners. And as you see, we were thinking about Jen, what she taught me. We went through personal health goals, past successes. Very important to ask, who is cooking? Who is shopping? And would they like to come to an appointment? So often we are dealing with the monkey and not the organ grinder. So do bring the organ grinder along to the next thing. And then the low carb information that is based on what I just showed you. So they're given information. I don't make them do stuff. They want to. So it's their choice. I'm not telling people what to do. Very important to establish where you are. A lot of measuring. Particularly, I like waist measuring very much and what you weigh. And then, of course, that forms the basis of what you hope is cheerful, honest, sincere feedback. Giving people... Doctors don't always say to patients, wow, you've done amazing, you are amazing. But if we start saying you are amazing, it really is just good. It's good medicine. It's good medicine, because then they do more of it. Hooray, it's fun. Oh, right. Another point is we say that some people don't do well for a while. And how do you deal with people who are not doing well? I believe they don't fail. It's not a failure. You just talk in terms of, yes, you've gained some weight. I wonder why. I'm also interested in what you're going to do different in the next week. So they haven't failed at all. It's all about moving forwards. And then Jen's going to talk about the groups that we run.
Oh.
She was.
Oh yeah, I clicked. Yep. So we started off with the first study group. We ran a group over about 5 weeks. But now what we do is actually only meet every 8 weeks, which doesn't seem very often. But people from the original group are still coming, and we do a lot of the same things because the principles are the same. I think what's added into the group is the kind of magic, the group magic, which is where people are identifying with each other, they're encouraging each other, they're sharing tips about where you can get the cheapest almonds, dash down to Aldi, they're only so much, which is really, really nice. And obviously the people who've been going there for a while act as an absolute inspiration and beacon of hope to those people who are just joining, because if you see people bring their before and afters and they talk about they're off all their medication, that's inspirational and it's hopeful for the people coming in. So I think the group does have that extra magic. And of course there's always Dr. Unwin's 3-minute soup demo, or I tend to bring in stuff for people to try and share. So it's lots of fun. We have a lot of fun with the group, don't we? Yeah. Okay.
This is just to reassure the nervous practitioners amongst you that we are actually now working with nice guidelines. Hooray. As from last December, you'll see we are supposed to encourage high fiber, low glycemic index sources of carbohydrate in the diet. So it's great. After years and years of hiding, I can come out because it's there in the guidelines. Fair enough. Also, we are supposed to individualize recommendations for carbohydrate. I think I'll do that. Good idea. One thing is just to say, when you're looking at low glycemic index sources of carbohydrate, there are just about no breads that have a low glycemic index, just about none. So bread's kind of out, really. Wholemeal, whatever you, bits in it, no bits. They all have a lot of sugar in there. Next thing, people often want to corner me into how many grams of carbohydrates do I make my patients eat, and why aren't we measuring? And I get things from people saying, tell me, you know, what do I tell my patients to do? The point is, the important point is that motivated people with information don't need telling. They can make their own minds up, and they do. So all I can tell you that given that information, the results are what you see. How patients achieve this is very individual because each of them lives in a very different environment and they have to tailor my information according to their lives. So handing out leaflets with details of what you should eat, that's why it doesn't work so well, because people have to interpret it in terms of their own lives. Right, so a bit more, graphs. I love graphs. I really, really love graphs. So the GP EMIS computer system generates graphs easily. And this is a great source of feedback for my patients. And they go home with these. There must be thousands of these graphs all over Southport on fridge doors. So here we have one of our patients. And this guy was 43. And he presented last June. And he's consented for me to talk about his case. Now, he was 43, and his goal, if we're talking goals, was he was very overweight and lacked the energy to play with his children. And that was his goal. He wasn't interested in his diabetes. He was interested in being a good dad. But what was great is you can find a joint shared goal, because for him to play with his children, he needed to breathe better. And for him to breathe better, he needed to weigh less. And for him to have more energy, we needed to get his blood sugar down. And when I'd established that we could work together on that, yes, he did it. He did it. And there you'll see he went in a few months. So his diabetes was so severe, I was just on the verge of insulin. So I said to him, we've kind of got a choice here. We're looking at insulin, or maybe you might work with me. And look how well he did, because he went all the way from nearly on to insulin down there. And his hemoglobin A1C, his diabetic control now, is in the early pre-diabetic phase. And he's given up his metformin and his chronic pain relief. So many things he's given up. And he's playing with his children. Hooray! So we got to his goal through my medical interference, but he was well motivated. Well motivated. And you saw his cholesterol dropped as well, if that matters. Maybe I should worry now. I don't know. This is him, and I just want to illustrate the idea. I like the idea of you've heard of meta-analyses, where a lot of different things are looked at. I like the idea of a meta-intervention, where you do one thing and loads of things happen. So this guy, here we are, he went on the low-carb diet, and all the graphs look a bit the same. They're all coming down, but they're different things. So he has lost weight and he can breathe better. His diabetes has improved. But look at the bottom two. That's liver function. He had really bad fatty liver disease, and that went as well. At the same time as his blood pressure improved. Lots of things improved for that fellow. It was a meta-intervention. Get his diet right, and he's a healthy animal. Loads of things. You don't have to give the separate medication for the pain and the depression and the da-da-da-da-da. If you can get a meta-intervention, he has a life back, and that, I think, is, I hope, what that shows. Right, this is a different patient. Can I just ask, can you hear me at the back? You can hear me. Good. Right. So this...
Speed it up.
Oh, speed it up. She's telling me to speed up. Right, hurry up. Right, speed it up. I'm speeding.
Come on,
right.
keep going.
This patient illustrates loads of different things. So a point was, the question mark there, that was years before he knew me. What did he do? He was doing something great there. What was it? Moving along. He did the low-carb diet. It worked. And then it didn't work. That isn't a crisis. What did he learn? What did he want to do? And then the second time, he learnt it properly, and he's now the lightest for 20 years. So it wasn't a disaster, because that's the beginning of learning. Moving on.
Yes.
Oh, God, this is the role play.
Yeah. Is it the role? Do you want to do it now? Okay. Have we got time? It'll have to be really quick. Okay.
Right, quick.
So Rongan was saying, you can't do this stuff in 10 minutes. So we're not going to do it in 10 minutes. We're not going to do it in 5 minutes. We're not going to do it in 2 minutes. We're going going to do it in 1 minute. No. Yes, we're going to try.
Yes, right, quick.
Okay, and what we're going to do is contrast what David would have been doing 3 years ago with what he does now, and go.
Right. And we're speeding it up. I thought she said speak up. Yeah, right, we're speeding it up.
And he was going more slowly.
So, the years have gone by. The patient's coming in. She's going to meet Dr. Unwin, and it's about diabetes. So here we go. Hello, Mrs. Jones.
Doctor.
You know that we've done your blood tests, and I'm sorry to tell you, you've got type 2 diabetes.
Oh, God.
Yeah, and I know that might be a bit of a blow, but don't worry, we will sort it out. We will sort it out. Can I ask first, what do you understand by type 2 diabetes?
Oh, dear. Well, you remember my mum. What it is... Yeah. Oh, dear.
Well, I think the point is, you know, I don't think your mum took her tablets properly, and I know you will take those tablets. And it didn't end well, but, you know, even if the tablets don't work at the beginning, stick with it. We'll monitor you, we'll check stuff, and I've got other tablets as well. And, you know, so if the tablets don't work, I have others, and then there's insulin, so that we could help you. We really, really could help you. But, you know, and unlike you see your mother, she didn't come when her feet, you know, she'd come earlier. So please come early if your feet start going any different colour. And also your vision, watch out for your vision, and don't hesitate if there's a problem with your vision, because I will link you in with an optician. You will have yearly vision checks, and we will be looking at your feet. So we will see these things early. It will be, and I will refer you. On. Just one question: do you have much sugar in your diet?
I don't, because of Mum. You know, I can't.
Well, you know that happens with some people. They don't have sugar and they're diabetic. So you know, I don't know, but I will refer you to a dietitian. And let's start with metformin. Okay, that's the end of that one. We come back. We come back.
Okay, debrief. Forward in time.
Yeah, we're back. We're now. Mrs. Jones, in you come. Well, Mrs. Jones, you know we've done the blood tests, and I have to tell you, they have shown that you've got early type 2 diabetes.
Oh, dear.
But don't worry, we can work this out. I promise you, it's going to be fine. There's nothing that you can't sort out, I'm sure of it.
Yeah.
Just one question. What do you understand by diabetes?
Well, I know it's about sugar, but that's a complete mystery, because you know me, I'm really healthy and exercising and following the guidelines about eating.
You're following the guidelines.
Yeah.
But, so is there sugar in your diet, do you think?
No, I don't know. No. I cut all that out.
Let me just ask one question.
Okay.
That would help me understand where you are. What do you have for your breakfast?
Right, I have that. You know that Alpine without the sugar in? Some muesli, like a banana on that with my skim milk, and a glass of orange juice. Well,
that actually gives me hope. Because you don't know it, but there is loads of sugar going in that breakfast.
Way.
Yeah, and if we cut that back, because diabetes is about sugar, we can reverse this. It's not a problem. You just need a bit more information and we'll work it through. I do have an alternative. I mean, we could use medication. What is your personal feeling? We could do the medication, or you could maybe try the diet.
No, I'd really prefer to try anything else.
Okay.
Yeah.
Right. Okay, I think that's enough. You got it, didn't you, really?
Woo! Okay, that was speed work. Okay, so just quickly then, because we called the talk about Norwood and beyond. How does this stuff roll out? This was a little nervy moment at the BMJ Awards this year. David had his pointy finger out, and you want to beware when the pointy finger, and he was pointing at Simon Stevens, who's got his eyes shut, actually. I don't know what that means. Michael Mosley looking a bit defensive there, and Simon Stevens was saying, oh yeah, but it's all the Dr. Unwin effect, you know, it won't roll out, will it? So, does it roll out? Are you going to do this one? You do this one.
I'll do this one. So yeah, it's infectious. So this is friends and family. You've got them all there. There's my son-in-law. He's lost. Oh, he's gone.
Oh no! Don't look at that. Don't look at that.
Don't look at that one.
Don't look
anyway,
at that.
That's my son-in-law. He lost a stone, I think, in a month because he wanted his belly small. There's a neighbour up there, the top. He's amazing. The guy underneath is a friend. He was on insulin 6 times a day. He's not on insulin at all. And these are just people around us in the village. And there's paleo family, aren't they adorable down there? Grandchildren. Hooray!
Hooray!
Moving on.
Yeah. So. And perhaps we're most proud of. We know the Saving Dad people are here today. Well, what about that? Saving Mum. David's mum's here today. Stand up, Mum. Woo! Woo!
Yes.
This is David's amazing mum, who's 80 years old. She's off her metformin. She lives the most amazing active life. And Vicky, who's also here, who's a dietitian, and between the three of us, I think, well, she didn't need that much saving, and she saved herself a lot as well. But I hope we've encouraged her. And this is her winning the family plank off. Come on, Peggy. I'll get you this year. Okay, so that's her. And then quickly, we're nearly there now. 2 minutes.
The title of this is sort of diabetes and beyond. And the beyond here actually is Malaysia. So Nafisa can't stand up. Nafisa is right at the back of the room, and she is a professor. She's standing. Oh, she is a dean of a medical school and a professor. And her brother read our paper way over in Malaysia. He was very overweight on the left, diabetic. And so we say it's a sort of Dr. Unwin magic. No, it isn't. He just read the thing, took action. Look again on the right. He's lost 1/3 of his body weight in Malaysia. He's off his drugs. He feels great. Result. And Nafisa's got all the details of his case, and she's very happy to talk to you about that. Moving on, I don't know what happens next. Right.
Just up next.
Yeah, just to say that what, again, is it just some sort of personal magic? No, it's not personal magic. So we work with diabetes.co.uk to produce an online thing that anybody can have for free and do if you want. And the point is 128,000 people chose to do this since last November. So the interest in this is massive, absolutely massive. And the next presentation is far more about what happened to those people, so we don't need to talk any more about that.
Okay, so low carbon diet and hope. We think it's a really effective and cheerful way to work with people, and we hope you've all taken away some useful thing that you can take back to your own practice. And we're around if you want to know more. There's some of our references if anyone wants to ask us more about any of it. We're around.
Yeah.
I think that's us.
Thank you.
Thank you.
Forever.